Good morning, everybody. Good noon, good afternoon. We have a member of the crowd who has had a huge accomplishment and just shared it in the chat. Kevin, hello. Very nice to meet you. Congrats on becoming a doctor.
Thanks a lot, Robbie. It's a huge honor, and I think a lot of it is contributable to the CP solvers actually, because I uh, recently discovered you guys like a few months ago, and I
Hmm.
really got into differential diagnoses, and
Awesome.
it really leveled up a lot. And a huge shout out also to my colleague and friend, Dr. Alex Winkler, who's going to watch this episode
Oh,
at some
nice.
point because he was the one introducing you guys to me. So
Oh, that's
big
so
thank you to
cool.
all of you.
Very grateful to him. Very grateful to you. Huge congratulations. Very, very happy for you. Thank you for having your video on so frequently. It's a makes a huge difference. We're very excited for today because I get to co-discuss and with David. And I will tell you all that I'll tell you all a little bit of a secret. The secret of the CP Solvers Academy has always been to actively help the next generation of doctors that come after me to be better and to grow more. And the truth is that that comes from inspiration by our mentors. For those of us who were involved initially, Reza, Sharmeen, and I, and others as well. So our mentors really set us up for success in the way they taught us. And we wanted to put that on steroids by using technology and Zoom and the internet and everything to like pass that on to the folks who are coming. And I really think that it's already starting to happen. So whenever we're doing internal teaching sessions and I start to teach certain topics, I realize that like now the crowd in the academy actually has more and more knowledge and more nuance appreciation than I do in certain domains. And David is one of the first. He's been part of CP Solvers for it feels like 15 years, even though CP Solvers is only 4 or 5 years old. But I will tell you that every time an EKG shows up, I think of him because his knowledge of EKGs and his knowledge of other things as well, including POCUS, far exceeds mine. And it's so cool to start to see that happening. And pretty soon, I hope it's true for every single one of you, but I know it's going to be true of every single one of the CP Solvers Academy members, which is that if I do my job right, which is that all of you will far exceed me, and then I get to be dragged along your journey and learn from how much you've learned more than I, and it's so cool, David, to have that feeling around you, and I hope there's an EKG involved, but I think today you'll also demonstrate that you know more about many other things and will know more than I. So very excited to share the stage with you. I'll hand the mic to you and then we can introduce everybody else who is part of this session.
Yeah, thank you so much, Ravi. Truth is, yeah, like your knowledge and your kindness is, I think, like unbeatable, and um, the the it's impossible to like to know be the one that knows everything the most, but the amount of knowledge and like especially the attention to the details that you have is like yeah, I think uh, has no equal. And um like I don't well it's impossible, like um I don't know if anyone could get like the amount of teaching that you have, like the implications that it has for the most of us is like without equal. Yeah, I think. So yeah, very thankful for being here, and yeah, let's pass the mic to you. He or whoever is doing teaching
Yeah.
points.
You're too kind, David. I really appreciate that. But I will prove you wrong. That's my ultimate goal 10 years from now. We'll see. I'll remind you of this episode and I'll play it back to you 10 years from now when I'm sitting in your academy sessions learning from you. Today we have an all internal affair. Let's start by handing the mic to Shreya, who is doing scribing. Shreya has an important event coming up a week from now. Mic to you, my friend.
Hello everyone, I'm Shreya. I'm doing scribing today and I'm really looking forward to Himun's case and David's discussion.
Amazing, Shreya. And then Magnus, last minute sub for teaching points. Mic to you, my friend.
Hello everyone, my name is Magnus. I'm from Denmark, currently in Netherlands, and really excited for Heman's case and yeah, David's discussion.
Yeah, thank you so much, Magnus. A treat to have you here. I think you've been on a case presentation streak, and for those of you who don't know, Prof. Rez, I mentioned this to he. Prof. Rez reached out to me during his last case and shared with me that it was one of his favorite cases ever presented, and I shared that screenshot with he. Prof. Rez is not one for hyperbole, as the YouTube audience knows. He puts everybody in their place, and so when you do a good job, you'll know about it. So he even more excited for your case. Thank you so much for presenting it again. Maybe you can say a quick hello, and then we can jump into your learning.
Yeah, sure. It's my honor to present this case to my amazing teacher, Rabih, and always like I'm learning so much from David, so I'm so excited to learn from this case. And I'm doing the infectious disease rotation right now, and I'm learning so much. And Shiria, thank you so much for helping me out for the case. Okay, let's start. Yeah, so just a moment. Um, Okay, so chip complaint. Okay, chip complaint is fever and cough, shortness of breath, and right side chest pain for 10 days. HPI, a 52-year-old male with 10 days of fever, dry cough, night sweat, dyspnea, and the right side chest pain that he initially believed was a rib fracture after playing cricket. The pain is sharp and worsened with a deep breath and movement. He reports fatigue and reduced exercise tolerance and denies hemoptysis, abdominal pain, nausea, rash, dysuria, orthomnia. I will stop here.
As always, such a clear-cut and amazing presentation. Yeah, David, take it away. What are you thinking?
Okay, so yeah, I think like very common presentation. And what I think is more what distracts me the most is the temporality, because yeah, with inflammatory, I think this is an acute inflammatory syndrome localizing into the chest, and likely localizing into the lung slash pleura, given the seems like pleuritic nature of the pain, and also the cough. I think I've heard. So this could be just like pneumonia, but the what is a little bit striking for me in that sense is the temporality. Is like this being 10 days is a little bit odd for just classic pneumonia, maybe because most patients present earlier than this, but this could be perfectly uh, uh, yeah, community acquired pneumonia that has been complicated with an effusion, and other mimics of pneumonia, including yeah, lung gases, empyema, and also non-infectious diseases such as, for example, P with pulmonary infarction. And in this, like, I think everything here will depend on how the patient, well, if we see any other anything that is discordant with an inflammatory right-sided chest pain syndrome, or if we see any other symptom that dissuade us from going into that path, because if not, this patient probably would be as given some antibiotics, and yeah, and like, yeah, I think seems like a very classic presentation, but yeah, there is a lot of there are a lot of possibilities if the pathway is not the clear the common one. Yeah.
Yeah, no, I'm right there with you, David. I think that's superb. And, we've talked about this before in the academy. I don't think if we've talked about it publicly, but often we use shortness of breath, which the patient is presenting with, and chest pain as synonymous, and we merge them. And I think that is probably a good place to start. But as we've talked about a lot, sometimes when two things are present together that look a lot alike, you think there's no diagnostic value in them being present together, but I will share with you that that a chest pain, somebody hurting in their chest, really implies that well, I mean, let me phrase it this way, I suppose. The lungs have minimal to no pain receptors. So the vast majority of patients who have lung diseases like COPD or even pneumonia don't report pain. The vast majority of patients who have chest pain do not have associated shortness of breath because the vast majority of chest pain is of benign etiology and often gets discharged from the emergency room. So the presence of shortness of breath in a patient with chest pain is alarming because it implies that the syndrome isn't just, ow, it hurts, but rather, ow, it hurts and I can't function anymore because I exert myself and I cannot do it. So when you have a shortness of breath with chest pain, it makes a benign diagnosis very, very unlikely. And so you start to go inside the most important organs in the chest, which is the heart and the lungs. But we just said that patients with lung diseases themselves don't hurt. And so what are you left with? You're left with a variety of cardiac diseases that hurt, many of them do. But more importantly, the other C, everything that holds the chest together, i.e., the connective tissue, can hurt. This is why pericarditis, which is not a heart thing, it's connective tissue around the heart. That's why it hurts. This is why the pleura, when the pleura is infarcted or inflamed, it hurts a lot. So for me, the combination of chest pain and shortness of breath is a profound diagnostic value because it implies that either there's cardiac disease or there's connective tissue disease. And by connective tissue, I mean pleuritis or pericarditis. And I think, David, I suspect that's why you're so worried about the pleura and you keep bringing up the pleura here because of all the locations this can be, the fact that it localizes to the right side makes a cardiac cause or a pericardial cause much less likely. So this is a very suggestive story for pleural disease on the right side. And I, like you, am very, very worried about that possibility. And so I think the first step really is to confirm that hypothesis. And the good news is there are some very simple tools like a stethoscope, a POCUS, and an X-ray that in seconds can confirm that hypothesis. And only then can we really start to say, now that we've confirmed that hypothesis and localized the disease to the pleura, what is the nature of this disease? And we'll talk about that if we get there. But I encourage all of you to just sit with one simple fact. It's very tempting to equate chest pain and shortness of breath and have the same schema for both, but they're not. There is very little that lives in the world of a patient who has simultaneous disease. And the short answer is the two C's. Cardiac disease, namely in the form of ACS, but also some other rare conditions like Takotsubo and myocarditis. And the rest is connective tissue, pleura and pericardium. And I think here David is very suspicious of the pleura because cardiac disease and pericardial disease tends to be central in nature versus the pleura tends to be lateralizing. So this is a patient for whom I would take out my stethoscope, which I usually don't use, and actually listen to his chest because I think it might be very, very valuable. So let's see, David. I think you're onto something, and I'm right there with you. Let's see what Heman has in store for us.
Yes, as always, amazing discussion, and I will definitely listen to the long sound. Yeah, so hypertension, a patient has a past medical history, hypertension and amlodipine, and he was an immigrant from India 10 years ago, and he's been a chronic smoker, 20 pack years. And yeah, vital signs, heart rate was 102, respiratory rate was 28, a febrile O2 saturation is 95%, general mild distress but alert, cardiac regular rhythm and no murmurs, respiratory markedly decreased breath sounds on the right, mild tachypnea, and this time I like to share it. Chest X-ray. Shreya, are you available?
Oh, Heman, did you share it with Shreya for her to share, or are you planning to share your
Yes.
screen? Ah, okay, okay. Sounds good. Yeah, we'll wait for Shreya to pull it up when she can. Let us know if you're having any trouble, Shreya. We can go for it, Debbie.
Okay. So well, going first into this chest X-ray, I think this is likely hydropneumothorax. We can see a fluid level in the right side of the, like, in the right lung. That is clearly demarcated from, and it's not the typical morphology you see in yes, normal pleural effusions. So it seems like there's a fluid air level here. So I think also being this like so um, occupying all the thorax, I think this is an air level in the right side. So aside from the air level, we can see something like looks like uh, maybe a collapse of the medium or lower lobe in the right. That is, for me, we will need a CT here. It's difficult to see. This is just a passive atelectasia, or if there's any underlying pathology here. And truth is, in this chest X-ray, I don't see clearly a um, like left side lung pathology. But yeah, I don't know exactly if there's any interstitial lung pathology in the left. Maybe. And I'm saying that because when we see what seems to be an hydropneumothorax, um, there are I think that the differential is pretty narrow for this. So most of it, I think, it comes from lung disease, like lung pathology that can like rupture and produce this. For example, you can see this in some cystic lung diseases such as lymphangioliomyomatosis, or less likely in Langerhans cell histiocytosis. You can see this in some pneumonias or CAPs that are complicated than can cause pleural effusion, can like more likely lung abscesses that can like break. You can see this in TB. I just presented a very similar case to this one. I think it was maybe 2 years ago, from a young female with endometriosis. And this is why I remember this. And but likely not the case here because of the gender. And yeah, I think we will likely need a CT to understand better the pathology that is underlying. And
Oh no, did he freeze for you or
because
oh nice. Okay.
yeah,
Well,
because of the
froze for
pain
about
and
10 seconds, David. I think you
yeah.
said you need the last thing we heard was we need a CT, and then I think you cut out after that.
Oh, sorry. I think that yeah, we need a CT to understand better the underlying lung pathology, and we likely need some drainage to first to management wise, and then to get some tissue, like, well, some to know if this effusion that is likely exudative given the pain and the, well, all the presentation is just like is represents an infection, or is of other nature, such as, for example, chyle in lymphangioliomyomatosis. But this is yeah, I think less likely.
Maybe that's absolutely superb. I think that yeah, you don't need me at all here. And although I am grateful to be here because I think it offers me the opportunity to sort of distill down your excellent reasoning and your management. I'm sort of like explaining your explanations. And I think he's giving us the opportunity to make the distinction between chest pain and shortness of breath, and especially if it's right-sided, to make the argument for pleural disease. And I think you're seeing that bear out. But I think we have another unique opportunity here to discuss in a few moments of detail what it means to have pleural effusion and air in the same area. And so the same question we asked for chest pain and shortness of breath is, when you put them together, do you just get everything, or do you get a smaller number of possibilities? And if you listen carefully to what David said, it's actually a very small number of possibilities that can only exist in these two spaces. So I think a key question is, what conceptual progress can you make when you have a hydropneumothorax? And I will just start off by telling you that if you just start off with a pleural effusion, you will realize that a transitive pleural effusion is very unlikely here. That the vast majority of the source of this fluid is likely an inflammatory process or blood. You also will realize that the air is unlikely to come from a static source. So if you approach this from the less familiar lens of a pneumothorax and ask yourself, what are the most common causes of a pneumothorax? Trauma, and trauma definitely can cause compromise of the lung to cause air in the pleura and bleeding of the blood vessels. So this could certainly be traumatic. In which case, the nature of the fluid is not an exudate, it's blood. So this fluid can definitely be blood, pure blood, be from trauma. But if we believe that this patient's story is not compatible with trauma enough to cause a pneumothorax, then we're like, this is spontaneous pneumothorax. So what's the most common cause of spontaneous pneumothorax? It's usually patients with chronic interstitial or obstructive lung diseases, and rarely cystic lung diseases. Those three conditions are static, chronic, slowly progressive. And so when they cause a pneumothorax, they don't cause it as part of a rapidly progressive disease process. So it's helpful to classify your causes of a spontaneous pneumothorax into ones that are dynamic and rapidly progressive, versus ones that are static and cause chronic lung disease that slowly erodes into the pleura. Whenever you have an associated pleural effusion with a spontaneous pneumothorax, you have to prioritize a dynamic, rapidly progressive pulmonary process that causes a quick hole in the pleura. And so the priority here are inflammatory lung diseases that erode into the pleura, namely infections. So a lung abscess as a prime example of that possibility, aggressive pulmonary tumors, and yeah, so I'll leave it at that. Ultimately, how do you make progress in real life? I think you can't study the air, you can study the fluid. And if the fluid is pure blood, meeting criteria for a hemothorax with a hematocrit over 30, this is likely trauma. If it is exudative pleural fluid, it's very likely to be an aggressive inflammatory process, prioritizing cancer, prioritizing infection over anything else. If it is, however, none of those things, that's when the beauty of the rare possibility of it being chyle and this being lymphangiomyomatosis. But there's one feature about this patient that makes that exceptionally unlikely. And Debbie, do you happen to know why Lamb is? There's one thing that makes it so unlikely in this person.
Yeah, he's a male.
Yeah, it's a gender. Lamb is predominantly a disease of women of childbearing age, with estrogen felt to be a prominent risk factor. So the simple thing for you all to upload in your mind is the nature of the pleural fluid will help you make progress. Is it blood trauma? Is it inflammation, inflammatory pleural fluid, infection over cancer? The summary is the processes that cause hydropneumothorax are a subset of the causes of pneumothorax and the causes of pleural effusion that ultimately distill down to trauma, aggressive infections, or cancers. Very rarely do they result from the intra-abdominal to pulmonary migration of endometriosis, which is also unlikely based on this patient's gender. So I'll conclude with this. This is a very long spiel. The gender of the patient with a hydropneumothorax makes a huge difference. In women, there are two potentially chronic indolent diagnoses, LAM and endometriosis. When that is not relevant, as is true in this patient, the only thing you're left with is trauma or aggressive infections or cancers. And so we have to, what does this mean for us in the ER? This means that this process is not chronic. It's going to get worse and worse and worse and worse. We have to take care of this patient very quickly and control the process very, very quickly. If this patient were a woman, then the possibility of a more indolent chronic process like endometriosis or LAM would give us some room to breathe, but that's not the case in this patient. Thank you, He. I don't think we've talked about hydropneumothorax since David's a case, so great to have that opportunity. I'll hand you the mic.
Yeah, amazing discussion. Thank you so much. Yes, so for that, just a moment. Yes, so the chest X-ray saw a large right hydropneumothorax and the right upper lobe infiltrate in scarring. So as Sam mentioned, we put the chest tube placed pleural drainage catheter insert into the hydropneumothorax. Pleural fluid study showed pH 7.3, glucose 13, protein. I think, can you go back to whiteboard? So so the glucose 13, protein was 4.5, LDH was 1400, WBC was 1340, 64% was lymphocyte, RBC was 3000, ADA was 58.5, serum protein was 5.8, so protein ratio was 0.82, and the chest was done. Right upper lobe, small central lobular nodule with a branching linear opacities, possible right lower lobe consolidation, calcified lymphadenopathy, and loculate gas pocket with the right hydropneumothorax. I will stop here, and please give your wisdom.
So I think everything spokes like into the chronic nature that this process has. Like even if we see here an acute presentation, this is likely chronic process that has been brewing for weeks, likely. Not only because of the anemia, but yes, also because of the pleural fluid results that show an exudative process that is lymphocyte predominant and with very high consumption of glucose and pretty high LDH. So, well, like being these patients from India is like everything screams TV. I think every like other in if this patient were from maybe from the US, you would have to include also other differentiations such as endemic mycosis. I don't know if they are so prevalent in India. Maybe histo could be a possibility. And well, I mean, this patient is from India, but I don't know where he lives. If he lives in the US, I think you have also to incorporate this endemic mycosis into the differential. But I don't know. I would have to look if they also can raise the ADA as TV does, as we're seeing here. And yeah, I think the is like agrees with this hypothesis of likely an subacute infection with those ventricular nodules. Yeah, truth is, I think like my differential is mainly that one. Trying to think into other possibilities, I think like lipidic adenocarcinoma could also cause like, I'm not sure if centrilobular nodules. Would want to ask you, Ravi, if you know that. But yeah, could cause also this like these nodules. But I don't know if like I think this would be a pretty rare presentation with the hydroanemotaras for a lipidic adenocarcinoma. So I think yeah, I think I would be like interested in asking you this the presentation with both centrilobular nodules and hydroanemothorax in my mind represents like two different manifestations of a same disease, likely a unique disease. Like I don't think that nodules would erode and like break into into the lung and cause this hydropneumothorax. So I think this patient likely had a cavitary lesion that eroded, and this is what gave rise to the hydropneumothorax, and we're seeing like different manifestations of a same disease. But yeah, would like to know what do you make of that hypothesis, Ravi?
I think, David, it's a really powerful question you're asking, and that's actually the exact same question on my mind. I think, like you, I've interpreted the calcific hilar lymphadenopathy and the lymphocytic pleocytosis in the fluid as markers of chronicity. And I think the key question now is, we know that this patient's pleura has a hole in it. And the question is, well, maybe I can say it a different way. We have a high suspicion that since there is no trauma to the outside world, or there doesn't seem to be evidence of a connection with the GI tract on the CT scan, that the source of this air and the source of this fluid is a communication between the lungs and the pleura. Because where else could the air and the pleura fluid have come from? From the world, from trauma, or from the esophagus? And I think the very advanced question you're asking is, I know the pleura and the lungs are connected, but which entity eroded into the other? In most instances, the lungs have an invasive process that erodes into the pleura. And oftentimes, when you remove the air and the fluid and you allow the lungs to expand, you see evidence of that process macroscopically, a large tumor, a large lung abscess, a large cavity. And so I think the question you're asking is, you're making a statement. I don't think these lung nodules are evidence of invasive disease themselves. So are they serving as a marker of a large cavity that has vanished because it is completely burst into the pleura? Alternatively, you can have disease that originates in the pleura that perforates the lungs. And I think the best example of that you already shared with us a long time ago, which is thoracic endometriosis. So what happens with thoracic endometriosis is that endometrial implants migrate through the diaphragm into the pleura and make a hole from the pleura into the lungs, as opposed to the other way around. So it's a helpful subspace to be in, to essentially have CT negative hydropneumothorax, or rather CT underwhelming hydropneumothorax. And I think the question you're asking is it underwhelming because it's vanished and gone? It was there before the hydropneumothorax and now it's gone? Or is it actually a primary pleural process? And I think it's hard to know for sure. But there is a competing alternate hypothesis, which is this is a primary pleural process. And what could that process be? It could be a primary pleural tumor or a primary pleural infection. And yeah, I think that calculus is really, really interesting. But ultimately, the progress that I think we need to make is to first study the fluid and see, what does that tell us? Do we find something in the fluid like a bug or a cancer? Or do we need to go inside the chest, do a direct visualization of the pleura and to see what's happening there? Because I agree with you, the lung process is underwhelming. So I'm open to both, but there is a concept of a primary pleural disease that erodes into the chest. So we'll see where this goes. All right, Mike, to you. Very, very interesting, Keith.
Yes, yeah, amazing discussion. Yes, we did a pleural biopsy. It shows caseating granuloma, and AFP1 plus was positive, and culture was positive for Mycobacterium tuberculosis. The chest CT, the small central lobar nodule with a branching linear opacity, is another word to call like tree in bud nodality. I think everybody heard about that. And then also, as Rabih mentioned, that TB can form like caseating necrosis near the pleural surface. So when the necrotic cavity rupture, it releases air into the pleural space, causing pneumothorax. So while simultaneously stimulating like a lymphocyte predominant, we've seen like high ADA in here. So the patient start ATT, the antituberculous treatment with rifampicin and isoniazid, ethambutol, pyrizinamide for like 2 months, and then 2 months, and then 4 months is like isoniazid rifampin. But after 2 months, he developed severe itchiness and rashes and like diffuse rashes around all his bodies and hair loss and hyperpigment patches. And then several days later, he had the oral lesion showing a fine white lace-like lines. So could you share your wisdom? What's going on with this patient? Maybe Shreya, is it okay if I feel like I'm asking a lot to share the last picture that we shared? By the way, you are doing a wonderful job.
Yeah, sure. Can you see the screen?
Yes.
Oh.
Yeah, Shreya, right now we're seeing the whiteboard. I don't know if you have the.
Okay, yeah, that's what I was asking.
Yeah, no worries. Maybe while Shreya, you pull that up, David, what are your thoughts about the initial diagnosis?
Can you see it now?
Yes, yeah, we can see it now. Shreya, thank you.
Yeah, I think you were right as always. So yeah, this is likely both like lung, like yeah, pulmonary tuberculosis and also pleural tuberculosis, which gave rise to the hydropneumothorax. Interesting. I forgot that because my patient with endometriosis also had pulmonary endometriosis. Like she had also lung involvement and hemoptysis due to that. So yeah, so yeah, that for the DX that we had just hear about. And so now yeah, the first thing I was thinking of is I would like to know an HIV serology in this patient because I don't know but just well the TB could be yeah, you can have just a patient with from India with TB, but would like to exclude any underlying immunosuppression. And yeah, I think yeah, I would want a HIV serology for this, just when we have the TB diagnosis. But yeah, also after hearing the alopecia and hearing of white plaques, it came to my mind both HIV and some of their complications, such as yeah, first of all with the like that purple lesions, the possibility of Kaposi, and yes, just because of it's very classic the color. And I don't know where are these lesions precisely. He
Yes, it's
precisely
all around the bodies. And also, yeah, HIV was negative, and hepatitis were negative, B and C were negative, and EBV, CMV, they are all negative.
Okay. Yeah, very useful. So I I don't know exactly what are these lesions. I think this is like I haven't seen really a lot of cases of TB, and TB can do very different things in the skin, but don't think these are likely lesions from TB. And the oral lesions are also, yeah, I don't know what these are. These I understand these are not like how do you say that, lesions that you can wide out, like right? These are very adherent to the mucosa, I think. Likely not candida or something like that. Yeah, we likely need tissue here, but I'm a little bit lost. Ravi, what do you think?
I think your rendering of the diagnosis of lichen planus-like lesions is very wise because the findings that you're seeing are consistent with what's called Wickrams striae, these like infiltrative lesions on the buccal mucosa. And then the image you're seeing, I think, is characteristic of lichen planus in that you have purple pruritic papules. The thing that's unusual is how abrupt it is and how extensive it is, and the relationship to TB. And I think it's a reminder that TB treatment is not without toxicity. And there's a category of lichenoid-like reactions, lichen planus-like reactions from isoniazid and pyrazinamide. And so I think if you just apply the simple principle that while the patient got better, they developed a new thing, you start to suspect drug-induced disease. And the complications of the anti-tuberculous therapy are so many. So I think naturally you might be inclined to look this up and be like, hey, can lichen planus be a consequence of TB treatment? And I'd be curious what that looks like. But I've heard of lichen planus-like reactions from isoniazid, I think most commonly, but I think pyrazinamide has also been implicated. Um, so I think when you start to see a small thing get worse, but everything else get better, it really helps us zero in on drugs. So that would be my leading guess, but I want to learn from what she has in store for us.
Yeah. Ravi, you're always reading my mind, right? So yeah, so that's yeah, so after 2 months, like he developed severe itchiness and then diffuse violess rashes. And then we really thought that it's a widespread of rhinoid eruption because of the ATT, the medication that we use. So ATT was all medication was stopped because we don't know what really caused the rashes. So the patient was treated with hydroxyzine, antihistamine, and the moisturized liquid paraffin, and the clobetasol, and skin has been improved was after stopping the medication. And he was placed on the levofloxacin and linezolid during the interruption because we cannot use the ATT. So after 4 months of off ATT, the lesion was stabilized. So next question that we are going to know is that can we start the ATT, and then which medication can we start first? And then my question was, this patient has been taken care of with the ATT for 2 months. Do we have to like just do the 4 months, or is it 4 months is enough, or do we have to do more months? So if David and Rabih can guide us how to like explore more, that would be wonderful.
David,
This would be a lot.
I'm a DX doctor. I don't know how to do any treatment of any kind. Do you
I
have
know
any
less than you. So as as Res, I would say I would chat GPT it.
Your Reza impression is spot on, my friend. Yeah, Himun, I love your appetite to teach us. You're teaching us about hydropneumothorax. You're teaching us about diagnosis of tuberculosis. You're teaching us about lichen planus. And now you finally reached the limit of my knowledge. Teaching us about ATT therapy. I have to put my hands up, confess my complete ignorance. So maybe you can teach us these because I have no wisdom to offer. Unfortunately, I'm gone, empty. Mike to you, my friend.
How about you, David?
I have no idea. Really.
Yes, I had really no idea like before I take the infectious disease course. So yeah, so it was very interesting because I thought that 2 months and then the patient was still on antibiotic. I thought it would be okay with the using 4 months, but that was not right in this case. Because rifampicin is really most important medication. When you use rifampicin, you can really reduce the duration of ATT medication. So you always start with the rifampicin first. So rifampicin was introduced first, followed by the isoniazid, and then pyrizinamide. But ethambutol was avoided. They thought that it could be the risk of having more. So he completed 9 months of therapy from the time rifampicin was restarted. So yeah, so he need a longer therapy because 4 months interruption for severe drug-induced rhinoid reaction meant that his initial TB treatment was incomplete, requiring full restart and extend the course to ensure the cure. Because TB can regrow during long interruption, so partial treatment increases relapse risk. So guideline require full uninterrupted courses when they resume. So yeah, that was the learning that I learned from the infectious disease.
I can't believe how much you taught us. You taught us about uh, diagnosing pleural disease, diagnosing hydropneumothorax, diagnosing pleural tuberculosis, and lichen planus, and management of TB. This is a very, very rich hour. David, how did it feel for you? What was new for you in terms of learning? What will you remember this case for?
Yeah. Well, of course, I didn't know anything about the ATT inducing like lichen planus and the possibility of lichen planus like being so abrupt and so diffuse. Something that wasn't at all in my mind. And yeah, I think is something that I would have to read more is that yeah, the fact that a pleural disease itself can cause like pneumothorax. Also, like you usually like at least me, I usually think of like pleural diseases or diseases, yeah, that are ascending in the pleura, causing pleural fusion, but not pneumothorax. But yeah, that is something that I have to keep in mind. Yeah.
I think that's a beautiful place to reflect on. Yeah, we'll have an academy session on it. What sparked my curiosity about what I think is the most important medical topic here, which is to learn about pleura going to lung, is a VJ presented a rapid fire in the Academy of Paragonnomyosis, which actually migrates through the diaphragm into the pleura and then into the lung. And from that story, I learned of this concept of a primary pleural disease causing a hydropneumothorax. And that's when it became clear that there's a theme: mesothelioma, pleural lymphoma, endometriosis, paragonnomyosis. Very, very interesting. Yeah, so I think he is really reinforcing that concept today. This patient has pulmonary and pleural TB, but I think, like you, that the pulmonary disease is more benign. It's just nodules. The pleural disease here, I think, was the sinister, aggressive version of the disease. And just for all of you to know, you might say, wait, is this all really chronic? And I believe that most of it is, but pleural TB is one of the most acute forms of the disease. The median time to presentation of TB pleuritis is a few weeks, unlike all the other forms of TB, which are often a few months or even maybe years. So Reza presented a case on RLR of somebody who had pleural TB that was as a result of reactivation from a TNF blocker. And that patient presented with 5 days of symptoms. So, yeah, I really believe that he probably has had long-standing indolent pulmonary disease as manifest by the nodules and the calcific lymphadenopathy. But I also believe his story of 10 days of pleural disease, because he was able to play cricket 10 days ago. And so that's just yet another reinforcement of the concept of TB pleuritis as an aggressive, hectic, rapidly progressive form of the disease, unlike the typical indolent months-long presentations of pulmonary disease. So much learning in this case. A real treat to hang out with both of you, and very grateful to Shreya for the toggling and the management. Hopefully it wasn't too stressful. We got to learn a lot from it. And now we get to learn from Magnus. Mike, to you, my friend.
Thank you. And as always, yeah, thank you for an amazing case, Hemon. They're also always so full of learning. And we started with a 52-year-old gentleman who came in with symptoms of inflammation and chest symptoms such as cough, shortness of breath, and chest pain. So here we could start to think about the different compartments of the chest that could be infected. So we could have a community-acquired pneumonia in the lung. We could have empyema in the pleura. We could have heart disease like myocarditis or pericardial disease like pericarditis. And then we saw that this patient had both chest pain and shortness of breath, which make us worry because usually lung disease in itself does not cause pain. And patients with shortness of breath usually do not have chest pain. So when we see these two together, we should start to think about cardiac disease like ACS or Takotsubo myocarditis, but also remember connective tissue diseases, which is mainly in the pleura or in the pericardium. The next step in this case was really the chest X-ray that revealed air and also a pleural effusion. So this patient had a hydropneumothorax. And then the first question should really be if there's been any trauma, which could cause a pneumothorax along with bleeding. But if there's no history of trauma, we start to wonder why this patient should have a spontaneous hydropneumothorax. And that's where we consider structural lung diseases, which could be divided into obstructive, such as asthma and COPD, interstitial lung diseases, or cystic lung disease. And in this case, we should also wonder about the tempo of disease. And if we see a rapidly progressive disease, that prioritizes either an abscess or a cancer. And if this patient had been a woman, we should also be thinking about lymphangioliomyositis that would cause chyle in the pleural space, or endometriosis. And another way to approach this problem is to think about why we have a hole in the lung. So usually we could have a lung disease that's like invading into the pleura. And that's probably the most common pathway. But in this patient, the CT findings was quite underwhelming in the lung. And that's why we were started to thinking of a pleural disease that could invade into the lung. And that's where we think of primary pleural tumors or infections or endometriosis. And in this case, the calcified lymphadenopathy and the lymphocytic pleocytosis was concerning for TB, and that's why a pleural biopsy was also performed, which showed TB. And the patient was treated with HCT, but developed purple pruritic papules, which could be a lichen planus, or it could be a lichenoid reaction. And Himon told us beautifully how to manage that in TB medications. So I'm just gonna let that stand for itself. But thanks again for such an amazing hour.
Man, this is unreal. I feel like you discussed this case. Honestly, that was such a clear distillation of the teaching points. And I think all of you will see if you, as you're striving to emulate Magnus, to see the clarity is probably reflective in how he managed the whiteboard. And you can see that 4 simple points highlighted with details. That was unbelievable, Magnus. Really another level of teaching points. Thank you so much. A lot of gratitude to you all. Thank you for this awesome hour, and I already look forward to the next time.